and welcome to the very first EMEUNET Paper of the Month interview. I am Dr. Mary Canavan from Ireland, and today I have the great pleasure of speaking to the first author of the winner of the EMEUNET Paper of the Month. I am joined with Dr. Stefano Alivernini from Italy, and he will discuss with us today his recent Annals of the Rheumatic Disease paper, Synovial features of patients with rheumatoid arthritis and psoriatic arthritis in clinical and ultrasound remission differ under anti-TNF therapy, a clue to interpret different changes of relapse after clinical remission. Dr. Alivernini, welcome and many thanks for taking time to participate in this interview.
Thank you, Mary. I'm very glad and happy that our work has been selected for this very nice initiative by EMEUNET.
Great. So I'll start off. What was the rationale for designing this study?
It's well known that disease remission is one of the most important goals of the treatment of chronic arthritis as rheumatoid and psoriatic arthritis. And despite clinical remission defined using clinical-based criteria, patient can still experience joint damage progression. Therefore, the use of ultrasound assessment testing the synovial hypertrophy and the power Doppler signal presence is able to identify in more than 50% of RA patients in remission signs of subclinical synovitis. Therefore, in a previous observational study that we have conducted, we found that using a combination of clinical and imaging selection criteria is possible to select a patient with less chance of disease relapse after treatment tapering or discontinuation. However, disease relapse still can happen, and limited data were available on the synovial characterization of RA patients in remission so far. Moreover, recently a paper was published showing that psoriatic arthritis patient in minimal disease activity has got a high chance of disease relapse after interrupting their treatment, and no data were available on the synovial tissue characterization of psoriatic arthritis patients in minimal disease activity.
Great. And maybe perhaps you could talk us through the main findings of the paper, maybe using some of your slides?
Yes, sure. As you can see from the graph, we included in the study RA patient reaching clinical remission defined as a disease activity score over 44 joints less than 1.6, combined with a negativity of the power Doppler signal. And we included as comparison group patients with RA reaching low disease activity using the same treatment scheme, in particular conventional DMARDs plus TNF inhibitors, and a comparison group of active naive RA patients that were naive to any pharmacological treatment. And analyzing the inflammatory infiltrates, we found that synovial tissue obtained from remission RA patients show significantly less inflammatory cells in terms of macrophages, T and B cells, and a reduction of the synovial follicular structures rate compared to patient at disease onset. And interestingly, all the follicular structure that we found in patients with residual synovitis were negative for follicular dendritic cells. And moreover, we did not find any significant differences in terms of inflammatory cells infiltrating synovial tissue comparing patients in remission and in low disease activity after stable treatment. And as you can see, we checked even the vascularity of the in the synovium, showing and finding that RA patients in remission have got a significant degrees of the mean number of CD31 positive synovial vessels compared to patients at disease onset, and no difference were found comparing patients in low disease activity and RA in remission after combination treatment of conventional DMARDs and TNF inhibitors. Moreover, to assess the inflammation resolution, we checked the amount of deposition of collagen within the synovium, and we found that there's a progressive increase of collagen deposition in the synovial tissue of patients array in remission compared to patients at the disease onset without any previous treatment. And no differences were found in comparing patients in remission and patients in low disease activity despite the negativity of the ultrasound assessment. And interestingly, using an additional comparison cohort of patients with psoriatic arthritis who reached a stable minimal disease activity status with a stable negativity of the ultrasound assessment using power Doppler signal, we found that despite the negativity of the power Doppler, psoriatic arthritis patients showed a higher rate of residual synovitis in terms of synovial macrophages, T cells, and a high number of synovial vessels.
Great. And why do you think the ultrasound negative PSA patients in remission have more synovial inflammation than the ultrasound negative RA patients?
I think that this is a very important point since, as I mentioned before, it has been shown that psoriatic arthritis patient reaching a minimal disease activity has got a high chance of disease relapse after treatment interruption. And the authors of suggested that the joint affected during the disease can home inflammatory cells that can give and provide memory function of the tissue that can lead and promote further inflammation even after minimal disease activity achievement. And in our study, we included psoriatic arthritis patient in minimal disease activity with negativity at the power Doppler signal at the US evaluation, finding signs of chronic synovitis as a higher degree of vasculature and inflammatory cells as macrophages and T cells, suggesting that an ongoing influx of cells could happen despite the minimal disease activity achievement. Moreover, it's possible that even additional cells not included in our study as mast cells that other groups demonstrated not to be affected by TNF inhibition can promote the inflammation and so could be responsible even in part of the disease relapse after treatment interruption.
Yeah, very good, very true. And again, I'm just wondering, within the RA group of patients, did you also look at seronegative and seropositive RA? And if you did you see difference in synovial inflammation at remission?
Actually, we perform a sub-analysis of these on this topic, and that these results were not included in the paper, but we stratified the RA patients in remission and with negativity of the power Doppler, the US assessment, and they've been stratified according to the positivity for ACPA and the rheumatoid factor. And we did not find any significant difference in terms of inflammatory cells characterizing their residual synovitis based on the autoantibody positivity.
Okay. And what do you think the clinical implications of this work are?
We believe that the results of our work could have relevant implication, mainly for identify a better knowledge of what from the biological point of view clinical remission is, and even to better stratify patient in clinical practice for wise treatment in the choice of treatment tapering or discontinuation once the best clinical outcome is reached. Over some of the results that we obtained in the study, in particular analyzing the synovial feature of patients with RA reaching a low disease activity that actually were not different from patients in DAS-based remission, but according to the both negativity of the power Doppler, this could be very helpful for their clinical management in terms of maybe tapering that could be even a reasonable choice for such patients.
Yeah, absolutely. And I suppose in maybe a sentence or two, what do you think is like the overall take-home message of this article?
I think that the take-home message of this article is that despite clinical remission and negativity of activity of the tissue due to the negativity of the power Doppler signal, RA patient and psoriatic arthritis patient differs in terms of residual synovitis after remission achievement, and these kind of results has to be taken into account for a better stratification of patients in the possible choice if they are not eligible or for treatment tapering or discontinuation in practice.
And one final question, what unknowns related to this work do you feel still need to be explored?
I think that until now, few data have been provided about the Synovial characterization of patients in remission, and lots of work must be done on this topic. And since it has been described that significant reduction of inflammatory cells when is observed when patients reach remission, some cells still persist in the synovial. For example, macrophages are still within the tissue, and I believe that a more comprehensive analysis of such cells, for example, their specific phenotype, would help a more comprehensive understanding of the immunohomeostasis of the joint. And moreover, it will be very useful to design a prospective study including even multiple parameters, for example, clinical imaging and tissue-derived parameters in the selection of patients, even to confirm the utility of these different possible biomarkers for the treatment choice of patients in remission.
Yeah. Fantastic. Let me just thank you again for sharing this really interesting work with us, and congratulations again on being the first winner of the EMEUNET Paper of the Month.
Thank you very much, Mary, and I would like to thank EMEUNET for this great opportunity and this fantastic initiative.